Alright, so we have my complete client assessment, and my client will be Kara Kraus, and that's who we'll be evaluating. Starting with our anterior static assessment, we are looking at the 5 main points of the kinetic chain, and we are looking at the feet, the knees, the hip, the shoulders, and the head and neck. What we're looking for is the feet to be parallel, which we can tell right here that her right foot is more externally rotated than her left foot. Then we're looking for parallel ankles, so the ankles are parallel. From there, we're going to work our way up to the knees. Everything seems alright. Then we're looking for the pelvis to be level. And it's a little bit of a rough angle from where we're looking at, but we can tell a little bit by looking at this right side that she has a little bit of a dip on her right side. So her pelvis dips down on the right, and her left side is more elevated than her right. From there, we're looking for the shoulders to be level, and this line here shows that they are not level. We're going to show that this right shoulder is elevated compared to this left shoulder. If we follow this line, we can see the point at which this shoulder meets the line and the point at which this shoulder meets the line are different. This is due to overactive upper traps, overactive levator scap, an overactive pec minor, and overactive latissimus dorsi. Some of the weak muscles might be the mid traps, the lower traps, the rhomboids, and the serratus anterior. So then if we go back down to the ankle, we can see that her right ankle is externally rotated as I stated before. This usually means that the overactive muscles would be the biceps femoris, the TFL, the tensor fasciae lata, the soleus, and the gastrocnemius. Some of the underactive muscles might be the glute maximus, the hamstring complex, the transverse abdominis, and the multifidus. Onto the lateral static assessment, we're looking for the foot and ankle to be neutral. We're looking for neutral knees, not hyperextended or flexed. We're looking for the pelvis to be completely neutral. We're looking for the shoulders to be in line with the knees and ears. And we're looking for the head to be neutral with no anterior head carry. As we can see here, my client from the last slide, her ankle externally rotates, and it's a lot more prevalent from this angle. As you can see, the left is pointing forward as the right is slightly outwards. You can see her shoulders are rounded here. As well, you do see an anterior head carry that is pretty prevalent from this angle. This means that since the shoulders are rounded, some muscles that might be overactive are the pectoralis muscles, the major and the minor, the latissimus dorsi, the teres major, the upper trapezius, the levator scap, the subscapularis, the sternocleidomastoid, which helps contribute to that anterior head carry. And then some underactive muscles would be the mid and lower trapezius, the rhomboids, the posterior deltoid, the infraspinatus and teres minor and the rotator cuff, serratus anterior, and also deep cervical flexors. In this view, I also notice forward head carry and overactive muscles, which would be the upper traps, levator scap, sternocleidomastoid, all listed before, the scalenes, the pectoralis major and minor as listed before, and the underactive muscles would be the deep cervical flexors, the mid traps, the lower traps, rhomboids, and serratus. So as we can see, the mid and lower traps, rhomboids, and serratus are weak, and they're listed again as being weak, so that will be something that is reoccurring in these slides. Now in the posterior static assessment, we are looking for knee valgus, seeing if the shoulders are even, seeing if the pelvis is in line, and looking for any scapular winging. So as you can see here with the same straight line, it is a little bit off, which is my error, but you can still see how the right shoulder is tight and propped up versus the left shoulder that is relaxed and lowered. And my client, I noticed that she had right scapular winging, so the overactive muscles would be the pectoralis minor, the upper traps, the levator scapulae, the teres major, and the latissimus dorsi. And the underactive muscles would be the serratus anterior, the mid trapezius, the lower trapezius, and the rhomboids, as well as the infraspinatus and teres minor, which also were listed in the slide before. And our next assessment will be the overhead squat assessment, and we're going to be starting with the anterior view. So this test assesses core strength, balance, flexibility, and neuromuscular control. And this was done in the anterior and lateral view. I'm looking for any feet change in any way, such as flattening, turning out, turning in, knee valgus, knee varus, or anything in between. So starting off in this anterior view, we're going to start the video. As you can see, if I play the video again, you can see she shifts the weight onto her right foot, and she is also unable to lock out her right elbow when starting the exercise, so I'll play that one more time. The weight shift, and then the push through. So due to this weight shift, some overactive muscles would be the right adductor complex, the right tensor fasciae lata, the right bicep femoris, and the right quadratus lumborum. Some of the underactive muscles would be the left glute med, the left glute maximus, the left anterior tibialis, and then also I noticed that my client had dumping in the hole, which will be more prevalent again on the lateral view. Moving on to the lateral view of the overhead squat. In this video you will be able to see, if you pay attention when I first play it, you will see that my client shifts her weight and rocks back and forth on her closer foot to the camera. So if we play this real quick, we can see that she tilts forward and then rocks right back. Play it one more time, you'll be able to see about halfway in the eccentric, you can see that she leans forward and then rocks back. If we play this one more time, we can see that she dumps her hips back. So right there, she dumps to get more range of motion. So this would result in overactive muscles being the hip flexors, as in the iliopsoas, rectus femoris, and tensor fasciae lata, the lumbar erector spinae, and the latissimus dorsi. The underactive muscles would be the glute maximus, the hamstrings, and the transverse abdominis, as well as her pelvic floor. To address real quick her inability to lock out her right elbow, some overactive muscles might be latissimus dorsi, teres major, the pectoralis major and minor, and the biceps brachii. The underactive muscles that would be affecting her ability to lock out her elbow would be weakness in her right tricep, her triceps brachii, the rotator cuff stabilizers, such as the infraspinatus and teres minor, her mid and lower traps, and her serratus anterior. The next test we have is a single leg squat, and we're starting with the left leg from the anterior view. So if we look here, we're going to see that immediately that the leg my client is squatting on, her left leg, her knee valgus immediately compensates due to the tightness in her glute med and tensor fasciae lata, and she also drops her shoulders and tries to shift her weight in her upper body to get out of the hole. So if we play this video, we can see she gets ready immediately. Her knee wobbles and she leans over to the side. Once she gets into the hole and tries to get out, you can see she rotates that right shoulder back and left shoulder forward to try and overcompensate for her tightness in her left leg. So we're going to play that one more time just so we can show that all together. Now, once we work our way to the single leg squat and the left leg from the lateral view, we can see again the hip transfer onto the right side and have her rotate her upper body. And we can also see that her left heel immediately comes up to compensate for her poor ankle mobility. So if we watch, we can see the heel comes up immediately and she rotates again. Keep an eye on the hips and the shoulders for the rotation. One more time we'll look at that. Immediately rotates the left shoulder forward, right shoulder back, and overcompensates. Moving on to the single leg squat in the anterior view for the right leg, we can see almost a nearly identical scenario as we saw on the left leg. I'll play that for you real quick. You can see knee valgus and rotates. One more time, knee valgus and that left shoulder comes back, right shoulder comes forward to try and overcompensate for her poor mobility in her right leg. Moving on to the single leg squat for the right leg lateral view, we can see that she does have better ankle mobility in her right ankle than she does her left, and she does refrain for some of that dumping she did on her left leg due to the improved mobility on her right leg. But we can also see, if you look at her hands, she pushes down on her shirt to try and create more stability for herself to get herself out of the hole. So if we look here, the mobility is a little better. Boom. She pushes right off her hips as soon as she gets in the hole. We can play that one more time. You can see there that she uses that to overcompensate. So some of the overactive or tight muscles might be the adductor complex, the tensor fasciae lata, the biceps femoris, the vastus lateralis, and some of the weak muscles are the glute medius, the glute maximus, the anterior tibialis, the posterior tibialis, and then I also noticed when she was rotating her shoulders on both the right and the left leg, some overactive muscles could be the left internal obliques, the right external obliques, the left adductor complex, the left TFL, and I would say honestly both adductor complexes and TFLs are weak, but the left side is much more apparent, especially with that lack of mobility in her ankle. Her right latissimus dorsi, her right pec major and minor, and right upper trap and levator scap could be contributing to that rotation at the bottom of the hole. Some of those underactive muscles could be the left internal oblique, the right external oblique, the left adductor complex, and the left TFL, as well as the right lat and the right pec major. Moving on to the modified Thomas test, we're starting with the left leg, or the right leg, I am sorry, there's a typo on my end. So for the right leg, I got my client up on a box with her leg hanging at 90 degrees, and she was in too much pain because of the tightness to do that, so we regressed down to a bench. As we can see here, her leg cannot reach 90 degrees, which means that the rec fem, iliopsoas, tensor fasciae lata, and hip flexor complex are tight, and some underactive muscles would be the glute maximus, the hamstring, the core stabilizers, and the posterior chain stabilizers. As you can see in this picture on the right, her right femur is in line with her torso, which is good for her rec fem. If we keep going, and if we move on to the modified Thomas test, we can also see here that the same issue with the knee not being at 90 degrees, but here we can see that her left leg is not in line with her torso. Again, this is the left leg, not the right. That is my fault. That is a typo. But we can see here that her left femur is not in line with her torso, meaning that her rectus femoris on her left leg is also very tight, and it is more tight than it would be on her right leg. The next assessment is the ankle dorsiflexion test, and this assessment measures the client's ability to dorsiflex the ankle. We are looking to see if the ankle is able to touch the wall, if her knee is able to touch the wall or has any compensation such as a heel lift, internal or external rotation, or any knee valgus or vagus. I noticed that my client's knee on both sides could not touch the wall, and if you look closely here, you can see that her hips do rotate to try and get closer to the wall. Some overactive muscles would be the gastrocnemius, the soleus, the posterior tibialis, and the peroneus longus and brevis. Some underactive muscles are the glute medius, the glute maximus, and the external rotators of the hip. The next test is the Davies test. We are looking for the trunk to remain stable and neutral, or with a neutral spine and a stable scapula. I noticed my client, if you can see from the posterior view, has scapular winging on both sides, but it is more prevalent on her right side. So with the scapular winging, some overactive muscles are the pectoralis minor, the upper trap, the levator scap, the teres major, and the latissimus dorsi. Some of the weaker muscles when it comes to scapular winging is the serratus anterior, which is the primary scapular stabilizer, the lower trapezius, the rhomboids, the mid-trapezius, and the rotator cuff stabilizers. She also had hip rotation during the test. So if we look here, one moment. If we look here from the posterior view and you look at her left hip, you can see right here that it dips down and then the right hip comes up. So we can look one more time, watch the left hip dip down, and then the right hip comes up. If you look here also, everything looks pretty normal there besides some forward head carry, which was already assessed. So with the rotation, we can see that the left adductor complex and the left internal obliques, as well as the right external obliques, the TFL and hip flexors in the quadratus lumborum are overactive and tight. And some of the underactive muscles would be the glute medius and maximus, especially on that left side due to the rotation, the transverse abdominis, and the metiphysis. Alright, looking at the gait from the posterior view, we can see here with the video that my client almost catwalks, but also she steps around and forward and then pushes off the inside of her foot and then steps onto the floor with the outside of her foot. So she pushes off the inside and then steps on the outside. And some overactive muscles are the peroneus longus and brevis, the gastrocnemius, the tensor fasciae lata, the adductor complex, and the biceps femoris. Some of the underactive muscles are the posterior tibialis, the anterior tibialis, the gluteus medius, the gluteus maximus, and the intrinsic foot stabilizers such as the flexor hallucis brevis and the abductor hallucis. Looking at the lateral view, we can now see also that toe off is much more prevalent, and she also has the hip swinging. So this often means that the lateral gastrocnemius, the soleus, the biceps femoris, the IT band, and the TFL are all overactive, while the underactive muscles are the medial gastrocnemius, the posterior tibialis, and the medial hamstrings. This is my client assessment, and thank you.